Good morning, everyone. Can people hear me okay? Hi, my name is Nasia Safdar. I'm a professor and a clinical infectious diseases physician at UW Health. I've had the great fortune to be working with many faculty members and graduate and undergraduate students in the College of Engineering for many years on our work. And today we're going to talk about something that's very near and dear to my heart to prevent, which is healthcare-associated infections. And although I suspect that most people are familiar with the term healthcare-associated infections, it wasn't that long ago that people thought that when they came into the hospital, they were going to be protected from anything bad that was going to happen to them. They were there to seek treatment for a specific condition and all would be well. And in fact, the reverse is often true, as we know. When people come into hospital or any healthcare setting for a variety of reasons, say a heart attack, they probably don't expect to find that they're at high risk for getting a subsequent collateral damage in the form of a healthcare-associated complication. And among the many healthcare-associated complications that we all know about, infections is still on top of the list. Now, most of the evidence suggests that infections are preventable, but as we'll see, it's neither simple nor easy to prevent healthcare-associated infections. So the objectives for today's talk is we're going to discover the current landscape of what HAI, which I'm going to be referring to, which is healthcare-associated infection, to look at the implementation of healthcare-associated infection prevention interventions, and we'll talk about one in particular that I'm collaborating on with Professor Weichman here. List 3 barriers to implementation within health systems, because too often we hear, why don't we just do it? We know that these things are preventable. Why is it taking so long, and why is it so difficult to do it? So despite many advances in the prevention of HAIs, it remains the case that 5% of all hospital admissions will result in a healthcare-associated infection. And so on an annual basis in the US, what does that mean? It means that it's almost 1 million infections each year, about 75,000 deaths, and billions in excess costs. And this is, of course, the numbers are staggering, and this is by no means trivial. But this is an underestimate of what the true damage that healthcare-associated infections cause in the US. And when we talk about the US, as a very developed nation, if these are the rates here, the rates in countries with fewer resources and up-and-coming nations that don't yet have the funds to invest in their healthcare systems, this is about 10-fold higher. So this problem is not just a US problem, it's really a global issue. So when we think about, what are these complications that we're talking about, and where do infections fall in relation to other things that you might see if you get hospitalized for something? So adverse drug events is on top of the list in terms of the costs and in terms of the toll that it exacts on people. And that includes things like giving too high a dose of something by mistake or giving the wrong thing altogether by mistake, and it's not detected in time. There are a number of systems like barcoding, for instance, and double checking and dual entry and so on that have been put into place to reduce the damage associated with adverse drug events. But still, what you largely see in the news are things like that. Somebody given millions of units of heparin resulting in bleeding and then death. But then look at the next few. So catheter-associated urinary tract infection, still very common in hospitalized patients, which is when you have a urinary catheter in place because you're not able to urinate on your own. Because this is a foreign device, it has associated risks with it, and one of them is a risk of infection. Central line-associated bloodstream infections, same concept. If people are in the ICU, they're going to need help in hemodynamic monitoring and getting medications to them through IV lines, but these things are not risk-free, and so you get a bloodstream infection. These things are typically not noticed at all in the community because you don't have devices necessary in the community. Then we have falls, some other obstetric adverse events, also very disturbingly common. Pressure ulcers, and then the next couple are again infections. Surgical site infections, you get what you might consider to be a minor procedure, and that results in a complication. And then an equally important one, which is the last one on the list here, is C. difficile infection, which is something that Professor Alagos and I have been working on for years, which is this whole idea of this is a very complex pathogen that completely ruins the gut microbiome of individuals, and very few options are available for treatment. Some of the challenges with these pathogens is not just that they affect the person that, in the case of C. diff, it's a fecal-oral transmission, so you have to somehow eat the pathogen, which is usually by way of it's either on the hands of yours or the hands of the healthcare workers. So there's the damage to the individual who's getting the infection, but then because it's shedding in the environment and is very difficult to get rid of, you will find that other people will acquire it and will suffer from it as well. And so those are the challenges that we have to deal with. And then when we look at the excess mortality estimates and the relative risk of mortality associated with these, you can see that these are not trivial, especially if you think that most of them can be preventable. You know, why should one have to suffer from the thing that you come in with, and on top of that, another complication that you might get? So the bulk of the healthcare-associated infections, and there are many, you can consider them in two categories. One is device-associated infections. So the device is an intravascular catheter, or the device is a urinary catheter, or the device is an endotracheal tube that you might need to have assistance breathing, which is a ventilator-associated pneumonia. And then there are non-device-associated infections, which are resistant bacteria. And so C. diff comes in there. The device in that case I would consider would be the antibiotic, because antibiotics predispose people to get C. diff. There are things like surgical site infections, not directly device-related, but there's a breach of the skin, and then you get a complication from that. You all may be very familiar with MRSA. It's been in the news and lots of articles written about MRSA bacteremia. It's amazing, you know, I was just on the infectious diseases consult service just a couple weeks ago, and 90% of the patients that we were seeing had Staph aureus bacteremia, whether it was MRSA or whether it was a susceptible equivalent called MSSA. So even though the media might get tired of reporting on these things, what we see in the hospital is that these things are very much alive and causing a lot of morbidity for our patients. Now, when we think about prevention of healthcare-associated infections, there is a long list of things that are considered high priorities, and every healthcare system has to have an infection control committee, has to have an infection control annual plan that then gets evaluated. And you can put down, in terms of priority, what are the things that you're seeing in your system that you want to be focusing on. And so for us, for many years, you know, other things will come and go, like COVID, for instance, but the CAUTI, the CLABSI, the C. diff, they've never really made it off the list because we've not made a sufficient dent in them to be able to say that they are considered, you know, dealt with. So they're still very much active issues. And then, of course, it's whatever the pathogen of the moment is, which for a few years at least was SARS-CoV-2. So what was our prior approach to preventing healthcare-associated infection? Well, a lot of it was apathy. It was felt to be the price that you had to pay for needing healthcare in a system such as ours. And it wasn't believed that it was preventable. People thought, well, you know, you're going to need an endotracheal tube, and one of the things that'll happen is that you might get pneumonia from it. So it was considered a necessary collateral damage of admission. Still is in many places, but fortunately, the tide is turning. And there really were no consequences, either to the institution or the healthcare workforce. The consequences to patients were often invisible to healthcare teams. For instance, if a colleague of mine is inserting a device, they go off service, 2 weeks later I'm on and I see the bloodstream infection, the individual who put the device in may have no idea that their patient has had a complication. At least that used to be the case. And so when you're insulated from the costs and the consequences of HAI, it's unlikely that you will be very invested in doing anything to prevent it. And oftentimes patients wouldn't be aware that this was something that could be preventable. You know, if you're comatose in an ICU bed, it's not likely that you will have a great deal of understanding of what is going on. And oftentimes when people recover from their coma, they have very little memory of what they went through in the ICU. So this is a very old study at this point, but I like to describe this to my students because it's very telling. You know, this was a very simple survey that these investigators who are considered world experts in catheter-associated urinary tract infection prevention. And they simply asked people, are physicians aware which of their patients have indwelling urinary catheters? You can't have a urinary tract infection that's associated with a catheter if you don't have a catheter. So knowledge of who has a catheter is presumably the first step in then getting it out and therefore preventing an infection. And they found that in 28% of these provider interactions or observations that they did, people were unaware that their patients had urinary catheters in place. And the unawareness rates were highest for the attending physicians and lowest for the med students, which it would be as expected because those are the individuals that are probably spending the most time with the patients, and so they're more likely to notice what devices they have. The attending physician goes in for a round but doesn't necessarily spend hours with the patient, and so they didn't know that their patients had urinary catheters. And because if you don't know that they have a catheter, it is more likely that then use is inappropriate because then you're not thinking that you should get it out right away. So a lot has changed in catheter-associated urinary tract infection, and primarily it's that we rarely put urinary catheters in place anymore unless there is no other option. And so that, I think, is a real success story. With central line-associated bloodstream infections, if you think about it, these are the 5 key behaviors. These haven't changed in all these years. And with these, line infections are considered largely preventable. So these don't seem terribly complicated, right? The removal of unnecessary lines, the washing of hands prior to the procedure, using maximal barrier precautions, meaning that the person inserting the line is wearing gowns, gloves, sterile gloves, a hat, any way that they can not transmit pathogens to the patient. You clean the skin with an antiseptic called chlorhexidine, and you avoid putting lines in places where there's a lot of bacteria, which is usually the groin region for many people. So again, doesn't seem terribly complicated, but look how old this study is. And where we are now is not that far away from where we were when we started, with a few exceptions. So some years ago, an individual called Peter Pronovost from Hopkins at the time felt that, this is really pretty unacceptable. If these are the behaviors that we have to undertake to prevent bloodstream infections, why is it that we can't do that? So he implemented a checklist which the person and the team inserting the device had to sign off on to say that they've done all these behaviors. And then he looked at what the rates were of CLABSI, or in this case, central line-related bloodstream infection, same idea. And what they found was that this was their baseline rate. This was around the time that they intervened. They trained the nursing and the physician staff to undertake those key behaviors to see if that prevented bloodstream infections. And for many months, they had zero bloodstream infections. This was a bit of a revolution at the time because that was not the case at all for most ICU settings. And their safety climate rose dramatically across these Michigan ICUs, which is where the study was conducted, and over time it improved. The safety climate piece is particularly important because there is a hierarchy in the healthcare system, and oftentimes if somebody's inserting a line, the other members of the team might not feel comfortable speaking up and saying, oh, look, your barrier precautions are actually have been breached, or you didn't clean the skin with chlorhexidine. And so the ability to empower any member of the device insertion team to be able to say, we have to stop and restart because there's been a breach of safety precautions. That safety climate is still a challenge in many places, but without it, you can't really expect people to speak up because there's consequences sometimes to speaking up. And the things that predicted clinical excellence was that caregivers feel comfortable speaking up if they perceive a problem with patient care. And in this particular study with that teamwork climate improving, they had no bloodstream infections. And now in the ICU, bloodstream infections are relatively uncommon compared to the non-ICU setting. But this comfort about speaking up, I think, remains a challenge that we have to work with in many places. So, there's the technical aspects of device infection prevention, which is that you're competent, you know how to insert it, you know where to insert it, you know what behaviors to do. And there's the adaptive aspects of it and the social aspects of it, which are equally critical, but are largely ignored with infection prevention. Infection prevention experts believe that if we just say the same thing many times, each time louder than the last time, that it will get people to change their behavior. But as we know, behavior change is an extremely complex, very difficult thing to do. Entire bodies of disciplines have been focused on change theory and change management. So it has to be a commitment from the top, saying that harm is untenable and make this harm visible. So in the ICU, what does that mean? It means that there's a large board right by the nursing station which says we have gone this many days without a bloodstream infection, this many days without a pneumonia, and everybody can see it, including the caregivers and including the patients. Without it, it was really infection control that held the data. And we could tell you what the rates were, but that's not the best way to disseminate information. And then we have leadership rounds where various leaders come to the ICU, talk to the clinicians and the teams, and talk about what the challenges are. Why is it that you're having issues with executing the procedures that will prevent device-associated infections? And then this sustainability piece is really important, which I'll talk about in just a second, which is that you can have a lot of interventions in place and you can think that they are baked in the infrastructure, but oftentimes there is considerable decay because there's a lot of competing priorities. So how do you guard against it and how do you prevent it is pretty critical. So with the patient safety movement, I mean, some of these things, seem very obvious, right? This is a patient safety problem. But you would be amazed. I mean, it took a paper in the New England Journal to point it out for people to say, oh, yes, we agree this is a patient safety problem. Before that, it was felt to be just like, part of the water of being in the healthcare system and nothing to be done. But other things happened that also motivated healthcare systems to really do something about preventing infections. And this is not just device-associated infections. This is also C. diff. This is also MRSA. And so the CDC has this National Healthcare Surveillance Network. Reporting into the CDC was optional for many years. So for healthcare systems that chose not to do it, they didn't have to. Now it's a requirement. And because it's a requirement, now you're having to disclose your rates, and that has implications for whether people will think that you are a good healthcare system or a competent healthcare system or not. The next step to this reporting, once the pretty astronomical rates started being reported nationwide, is that Medicare and Medicaid implemented this financial penalty. They said, we believe that these infections are preventable, and so if your patients are facing this, we will not reimburse you this extra amount that you would otherwise be entitled to. This penalty could reach in the millions for healthcare systems that have a large population of Medicare and Medicaid patients. And most academic healthcare systems are like that. And so, in addition to it being a patient safety problem and the fact that we were now reporting it was going to become visible, this financial penalty was another major incentive for healthcare systems to say, yes, we should devote some resources to preventing HAIs. And now this has become very commonplace that anybody can look at the rates of some HAIs, not everything, but some. You can at least get some insight into what the iceberg might look like. And so Checkpoint for Wisconsin is the website that many people can look at. And so here you have catheter-associated urinary tract infections, you have bloodstream, C. diff, MRSA, surgical site infection. Notice that, you can have surgery at many different sites, but a couple of the highest risk procedures are abdominal hysterectomy and colon surgery, and so those are the ones that they report. They give you a little bit of interpretation that the lower is better for this standardized infection ratio that they report, and they give you the reporting period, which often is delayed by quite a bit, almost a year or so in some instances. And then you can look at where you are in relation to other large systems. But everybody is reporting, so I've just filtered this out by these few, but there's a long list. And so you can see, we're doing well in some things and not so well in other things. And now that it's out there, patients can use this to decide, should I go to UW for my care or should I go elsewhere, depending upon what they believe the quality of care is. So for all these reasons, there was a decline in HAIs. Sometimes when you put something under major scrutiny, that alone is enough to reduce infection rates. And so that's what happened with central line-associated bloodstream infections. You can see that in the ICU population, the difference between 2001 and 2009 is pretty substantial in terms of the number of infections. In the inpatient wards, actually, there still is a considerable rate of CLABSI. And in other less conventional settings, like outpatient hemodialysis, which is the next frontier that we have to tackle with bloodstream infections. Healthcare has now become very, very fluid and very evolved. In the past, you were either at home, or you were in the hospital, or you were in the ICU. Now you can be at home, you can go to the clinic. From the clinic, you can be admitted to the hospital, where you might land into the ICU. You might go to a step-down unit after that if you recover. You might go to a rehab facility after that. And if that fails, then you might end up in a nursing home. So the whole spectrum of healthcare and the networks, this constant movement of patients from one facility to the other, means that you really can't look at HAIs as an isolated facility problem, which is a challenge because the reporting is done at the facility level. So systems have said, if I'm taking care of many sick patients, my rates of HAIs will be higher, but that doesn't necessarily mean that I'm doing something wrong or that I can influence it the way others can. Those arguments have not really worked. CMS is still holding the facility for the patients that they see. In our setting, we had this issue with catheter-associated urinary tract infection, and so we implemented a checklist to see if we could reduce our utilization rate, and then therefore our urinary tract infection rate. It included things that you might consider would be, not terribly innovative. We identified champions at the units. The champions went around and observed who had catheters. Every day they would ask the physicians and nursing team, can this catheter come out or does it need to stay in? We'd have people do nursing rounds around the units for the same reason, to make sure that catheters were being taken out. And then over time, as you can see, our utilization rate and our catheter-associated urinary infection rate also went down. This is the duration of catheter days. And so when you're taking the catheters out, then the number of days it's in place obviously goes down. And so we started out with some ups and downs, but over time, our number of catheter days went down dramatically. I should be fair and say that this doesn't always translate into a reduction in the infection, because a few catheters that remain in place, if those get infected, your rate may actually be higher now. But we follow the process. If there's no evidence-based reason for the catheter to be in there, it shouldn't be in there. That's the thing that's in the patient's best interest. So in our case, though, we did find that our catheter-associated urinary tract rate also went down with some ups and downs over time. When did we see these blips that were up there? It's when we failed to prioritize this. When something else came up, there was an outbreak of some other sort, or we had shortage in staffing, or we had people that were traveling nurses that weren't familiar with the protocols of the facility. Those are all typical reasons for why things might not do as well as you would think. So, these were big success stories. CLABSI was a success story for a while at least, and so is urinary tract infection associated with catheters. But C. diff seemed to be this really intractable problem that we couldn't get our hands around. And part of the reason is this. The complexity of C. diff makes it very challenging to contain it. And there isn't a single intervention that you can think of that would do all of these things, that would attack all of these channels of transmission. So C. diff, for those that might not be familiar with it, is a diarrheal condition. It's a very resistant bacteria. You ingest it. It causes diarrhea, ruins the gut microbiome and the healthy gut bacteria, and it has a high rate of recurrence. The initial diarrheal episode might not be terrible, but up to 35% of patients will get recurrence, and then it becomes this vicious cycle. And equally importantly, once it's in the healthcare system, because it sheds in the environment and the spores are resistant to cleaning by standard agents, they will remain there forever. And so there's actually some really interesting data which showed that if a patient with C. diff has been discharged from a room and the room has been cleaned as best as we think that it can be cleaned, the next patient that comes into that same room is at much higher risk of getting C. diff than if they had been admitted to a different room. I mean, that's pretty telling. That tells you that the environmental contamination with C. diff is pretty profound. There's also this need for soap and water for hand hygiene when you're leaving the room, which many people in healthcare systems are so used to the alcohol hand gel that it takes a real effort to remember that you need soap and water in this situation. And very importantly, you need both things. You need infection prevention and you need antibiotic stewardship, because stewardship is the thing that will prevent C. diff equally well, since the whole premise of C. diff is that it's caused by antibiotic use. It's not a study that I would replicate, but there was once a surgeon who drank a slurry of C. diff. He just made up a slurry and he drank it. And what do you think happened? Nothing. He had a healthy gut microbiome. He hadn't taken any antibiotics, and he was fine. But if he had been given a dose of clindamycin or any antibiotic, he would undoubtedly have had C. diff. So our healthy gut microbiome is very capable of protecting us from the usual pathogens, but it's when things get disrupted. You get surgery, you get antibiotics, you get devices. That's when your normal defenses fail. And in hospitalized patients, that's almost ubiquitous. So we made a fishbone diagram showing the complexity of C. diff, and we wanted to see what we needed to focus on. There's lots of things that you can do. And in part, it's actually because of the work we did with O's that taught us that not all of these interventions are going to be high yield. The natural tendency of anyone, I think, is to focus on behavior changes that are outside of us. It's much harder to look inward, much easier to blame somebody else. So we did a lot of focusing on this thing here. The education of visitors, the education of healthcare workers, feeling typical for infection prevention, that if we just educate people enough, that the right behaviors will happen. So we would spend a lot of time, especially people that came in to visit their loved ones. we'd say you have to wear gowns and gloves because you're going into a room with C. diff. And all of that is true. But the effort that was spent in doing that was enormous. And the yield is very low. We would have been much better off if we had focused on things like environmental cleaning, like screening for C. diff, and antibiotic stewardship. And so once you research this and you figure out what the right intervention is, you realize, you can't possibly do all of these things. You can't address them all. But the high yield stuff is the environmental cleaning. The high yield stuff is screening for patients for certain units where the risk is high for them. Now, this is an interesting study where they looked at, what about if somebody is not taking antibiotics? So just to orient you, this is C. diff infection for 10,000 person days, and this is antibiotic use. And these are various people that receive the antibiotics. So as antibiotic use goes up, your C. diff incidence also goes up. No surprise there. But when you look at, this was in a nursing home, so that's why, because it's the home for many of these people, they're calling them residents with direct antibiotic exposure, and people who are in the nursing home without direct antibiotic exposure. So the direct antibiotic exposure makes sense, right? You've received more antibiotics, you get a higher rate of C. diff. But the rate also goes up for people that are in the same vicinity but aren't receiving antibiotics. And that's where this whole transmission of the risk of C. diff comes in. There's a risk to the person getting the antibiotics, but also to people around. And that's because of the shedding of C. diff, which is why you have to really focus at the unit or the facility level, not always at the individual level. We and others have suggested that we should really try to integrate antibiotic stewardship and infection prevention using a team science approach. At the moment, these are two very robust programs, but they're largely siloed. So if there's a C. diff outbreak, stewardship might not be aware of it. Infection prevention might think that we have to take the lead, and that might be the right thing to do. But that communication between the two programs really has to be much better compared to what it is now. And all of this, has to happen. Obviously, anytime you have a new integration of two programs, there's going to be some conflict, and so managing that, reviewing our common goals, and then the shared vision of reducing HAIs is going to be critical. With Professor Carrion, who developed the Systems Engineering Initiative for Patient Safety, we decided to see if we could take antibiotic stewardship and apply it to the problem of C. diff and how we would do that. Many of you are, of course, familiar with this concept, but it was a bit of a revelation for us in the healthcare system because we hadn't really looked at it in this holistic manner. A clear example of this is that, in the healthcare system, when we put an intervention in place, we often don't think about what it means in the larger context of the work going on. So you could be doing one thing for the benefit of the patients, not realizing that there's unanticipated and collateral damage happening elsewhere. This is a very common problem. And this happens because you haven't looked at it systematically in all the ways in which things can hurt people, even though the intention is good. And this is the next version of SEEPS 2.0, where the patient is also central to the work, which is particularly important for many things like antibiotic stewardship, where the patient is the one taking the antibiotic. So how did we apply the SEEPS model to the case of antibiotic stewardship? So we went back to there's a number of guidelines, and this one is from the Infectious Diseases Society of America, which talks about how you would implement an antibiotic stewardship program. This is more complicated than it first appears because many physicians and other people that can prescribe, like mid-level providers, for instance, who can prescribe anything, but in this case, let's say antibiotics, feel very strongly that if you have the background competence and the knowledge that all the decisions that you're making are the right ones, which may be the case, that for the individual patient you're making this decision, but it may not help in the larger context of antibiotic overuse. There's plenty of data that suggests that when you ask people in healthcare, do you think antibiotic resistance is a problem? We will all agree that it is. Do you think it's a problem for you? We'll say, oh no, I don't think it's a problem locally. I think it's a global issue, but not in my context. So implementing a stewardship program was challenging because you had to get over that resistance to change aspect of it. But then there's a lot of ways that you can do stewardship. And our problem was that not many of these are necessarily C. diff specific. So you could, for instance, choose to do a proportion of patients converted to oral therapy. This is a good thing to do for patients, that if they don't need IV treatment, converting it to oral is good, but it's not specific to C. diff. that type of stewardship is not going to help C. diff. Excess days of therapy might be helpful because the longer you're on antibiotics, the higher your risk of C. diff. But again, if you have to substitute one antibiotic for another, and they're both at high risk for C. diff, it may or may not help. So we needed to be very careful to think about, out of these possibilities, what would we implement that would affect this particular problem that we were facing, which is the proportion of patients diagnosed with hospital-acquired C. diff. And hospital-acquired is generally 3 days or more of admission would be considered hospital-acquired. If you come in with C. diff, it's considered community-acquired, which is a whole other unresolved question about this arbitrary distinction between community and hospital. So when it comes right down to it, there are 2 ways to reduce antibiotic use. You can do audit and feedback, which is that you let people prescribe what they will, and then a day later you go back to them and say, this is what we found you had prescribed. We might have done it differently. Here's how we would have done it differently, and let's change it. This is not ideal from the standpoint of C. diff because the damage has already been done, and now you're just trying to limit the effect of the damage. The other is pre-prescription authorization, which is that you don't allow the prescriber to prescribe it in the first place, which is very challenging to do because, as you might imagine, people don't like being told what to do. No one does, really. So how would you do that? We decided to focus on the pre-prescription authorization because we felt that from the C. diff perspective, the audit and feedback, the damage has already been done. Your gut microbiome has been hurt and it wouldn't have the impact. So how do we do this intervention? So there's, of course, lots of frameworks out there for change management. We use the Cotter's model of change, which is that we got consensus on the reasons for why people were prescribing a certain type of antibiotic. It's very difficult to limit all antibiotics. Of course, people need it when they have infections. So we focused on a particular class of antibiotics called fluoroquinolones. Fluoroquinolones, when they first came out, were believed to be a massive advance in antibiotic therapy. They were oral, they were well absorbed, they were well tolerated, they had a big spectrum, you could use them for a number of things, until it became clear that they posed a high risk for C. diff. And so then the battle began to try and limit their use, which is tricky because when something is as convenient as that, it's hard to limit it. So we had to reach consensus on indications. When would we use fluoroquinolones, and when would we say we need something else to try and reduce C. diff? We went back to the literature to look at the data. Quite a lot of literature on the risk of C. diff with fluoroquinolones, but not a lot of data on what else to substitute for it. And most physicians, when you talk to them, they're very concerned about, obviously, their patients having good outcomes. So if I just went to them and said, you can't use fluoroquinolones, that wouldn't have gone anywhere. We had to give them an acceptable alternative that we were comfortable with from the C. diff perspective. So then we had to incorporate that into our local guidelines to make sure that everybody was aware of it, had signed off on it, agreement of what we would do if those guidelines were not being followed, and then we piloted it in a couple of high-risk units, which for us was our transplant unit and the ICU, which is where fluoroquinolones were being used a lot. So what did this intervention look like? What we wanted it to look like was that when providers attempted to order a fluoroquinolone in the EHR, an alert would come up, which in our case is something called a best practice alert, or a BPA would come up, and it would say that use of fluoroquinolone is restricted in this setting. And the alert will include giving them resources to what else they could use, instructions to call the unit pharmacist or infectious diseases if they felt that was necessary, and an ordering list of alternative antibiotics for their convenience so they didn't have to necessarily read about the resources if they didn't have the time. I think when you're not actually in the EHR, you forget about the impact that the EHR has on you. A single click too many can be the straw that breaks the camel's back for a busy clinician. And this is just one intervention. Imagine all the other things that you have to click into the EHR to do. So we had to really make sure that this was as user-friendly as we could possibly make it, which was a very big challenge. So then we also said that, if after speaking to the pharmacist, you feel that you still want fluoroquinolones because that's in the best interest of your patients, then you can contact the ID attending. And there was a small group of us that were willing to take the call and just to see what the volume of those calls would be and what we could help people with. And then if all of that failed and you still wanted to do it, you had to indicate in the EHR the reason why you were ordering the fluoroquinolone. So essentially making it easier for people to do something other than order fluoroquinolones. But as you can imagine, There could have been a lot of angst, right? It was a big change for people. Our culture was very fluoroquinolone heavy, and many people were eager to stay that way. This is what the screen looks like in the medical record. So this is a fluoroquinolone right here, levofloxacin. It's one of many. This is the instructions for how to give it. And then these are the alternative antibiotics. We say use of fluoroquinolones is restricted. This is now, a good 5 years or so ago. So now the culture is pretty well entrenched. We don't use much in the way of fluoroquinolones anymore. But you can see that we had to give them all of this guidance here. We gave them a lot of resources here, and we gave them the alternatives here for what they could use. And that, I think, was reassuring to many people. If they felt they had to order fluoroquinolones, these were the reasons that were considered acceptable, that they had talked to somebody and either that person had recommended it or they still felt they had to do it. And then these are some other restricted medications that are not pertinent to this. But the reason I have them in here is because you can see that fluoroquinolones is just one of many things that is restricted at University Hospital for very good reason. These are some very broad spectrum antibiotics that if we were to overuse, we would get resistance to them very quickly. So we try to limit their use. And some of these are no longer the case just because there's a lot of infections that need it. But that's sort of what the culture was. We knew that some things were restricted, people were used to it, so we added fluoroquinolones to the list of things. And then with the help of our engineering colleagues, Pascal and Doug and others, we collected data on implementation process to see, because you would be surprised, a lot of the literature on stewardship says, here's the problem, here's the intervention, and here's the outcome. And the outcome often is in terms of we reduced antibiotic usage, we reduced C. diff, but there's nothing in between of the how. How is this intervention put into place? And a very dramatic example of that in our own system many years ago was that we thought we had put an intervention in place. The outcomes were favorable. We were very pleased. Our intervention resulted in this outcome, only to find out several months after the fact that the intervention had never been put in place. So something else had reduced those outcomes. And so that can be very common in complex healthcare systems unless you track the intervention and you see that it's actually happening. And so that's why this implementation piece was very innovative for us, and it was very important for us to guide if we needed to tweak anything. So we created these training materials. We had a number of focus groups and interviews with attendings and with residents to see how angry they were with the intervention. Was it working for them? What needed to be tweaked? And then we did surveys on intervention acceptability. And we did have to tweak some things, as you might expect, but I think just the fact that people were being asked how the intervention was working for them went a long way towards building some goodwill and helped us be better at this. So fluoroquinolone use was going down even before this intervention, as you might notice here, but it really accelerated this decline. So in our pilot units, our rates of fluoroquinolone use went way, way down after this was put in place. Our rates of alternative antibiotics went up, so the total didn't change. But from the C. diff perspective, we were most interested in this going down, and so it did. And since that time, we have now implemented this in 5 other settings in a stepped wedge style. People have their own version of how they want to implement it. Not everybody wants to do it the way that we did it. But by and large, if you reduce fluoroquinolones, people are finding that you're reducing C. diff rates as well. Of course, there's a lot more work to be done in this case as well. But part of the thing that was interesting for us was to have a better understanding of why is antibiotic stewardship challenging. What is it about this particular thing, about limiting antibiotic use? And Julie Simzak and colleagues have done a lot of really interesting qualitative work to try and determine what it is about antibiotic stewardship that is so challenging. And one of the things that she described is that prescribing is a very social act. It goes way beyond clinician knowledge. It's a relationship between you and the patient. And even though intuitively you know that on a societal level, antibiotic overuse is a bad thing, you're not really concerned about that on a day-to-day basis. It's really the patient in front of you that you're most worried about. And there is a prescribing etiquette, which it took us a while to get over that in the sense that, if I as a physician have not seen the patient and I'm telling someone who has a relationship with the patient that they're prescribing the wrong antibiotic, unless you do it the right way, you can see how it could come across as being completely not something that anybody would want to listen to. You have to take into account the opinions and deference to people who are specialists in their areas, which is challenging sometimes for stewardship folks to do. And then a lot of risk, anxiety, and you cannot discount the effect of fear. This is fear on the part of the physicians thinking that their patients will have a bad outcome because they are changing antibiotics based on what they would usually do. This has to be addressed, otherwise we wouldn't get anywhere in the stewardship area. So the alternatives that we have proposed to fluoroquinolones were acceptable to the physicians. And when they found that the outcomes were good and nothing bad was happening to patients, that then allowed us to go from the pilot to house-wide and house-wide to other institutions as a dissemination. One innovation in C. diff has been the use of dogs to see if you can sniff it out, because it has these volatile organic acids in the stool. So this is not in the US. I don't think we would have that happen here, but in Europe, there was an institution where they had this beagle roam around in the wards, and he was actually very adept at diagnosing C. diff in patients just based on the smell of the stool. Actually, many healthcare workers also swear by the fact that they can diagnose it, and they're often right, although a blinded study showed that that was not the case. But in any case, this dog innovation didn't last very long because he got distracted by the smell of urine and other things, so they had to say goodbye to him. I don't think it's going to happen here anytime soon, but I thought it was an interesting study that got published. So with all of this now, where are we in the current climate with HAIs? You've seen that there's been a lot of progress made. You've seen there have been a lot of interventions. And then COVID happened, right? And what we found in COVID was that this success that we had experienced and everybody had enjoyed was very fragile, and it was easily reversed. And even though the technical aspects are different for each HAI, like how you insert a urinary catheter is going to be different from how you insert an intravascular catheter, but the social and adaptive aspects are likely the same. And it was that thing that fell apart during COVID. And so what did we find? We found that among acute care hospitals, there was a 24% increase in bloodstream infections during the time of COVID. The largest increase was in the ICU, and this was the place that had had the biggest decrease over the last decade in bloodstream infections. And so we're back to where we started. No significant change in urinary tract infection, about a 10% increase observed in the ICU, 34% increase in ventilator-associated adverse effects, a little bit of a decrease in SSI. And you know why that happened? It happened because during the time that COVID was worse, we weren't doing very many surgeries. And you can't have a surgical infection if you're not doing a surgery. So this was somewhat of an artifact in the decline because the denominator went way down. A little bit of decrease in hysterectomy SSIs, colon surgery for the same reason. Increase in hospital onset MRSA, 11% decrease in C. diff. This is very interesting, and it is a little bit unexplained because antibiotic use surely went up during COVID because with pneumonias, people were doing a lot of antibiotic use. So this was a little bit unclear, but part of the reason that people felt this happened is one is few people were coming to the hospital unless they were really sick. The preference was to avoid coming in. And so mild C. diff probably went underdiagnosed. And then the other was that the movement of patients from one facility to the other went down dramatically. So because most facilities weren't prepared or equipped or willing to take transfers, they didn't have the staffing. And so a lot less movement, and so C. diff stayed where it was, and because of less transmission, probably the rate went down. Since COVID, ended, at least the acute phase, C. diff rates have gone back up. So whatever it was a temporary thing. And then the last explanation for this is that diagnostic tests went down. When you had a patient with COVID, the default was that you would try to do as few tests as possible, as few interventions as possible, because you didn't know the risk to other people. And so oftentimes you would just treat for C. diff without diagnosing it, which means that your rate would be artificially low, but the problem would still be there. So for all those reasons, we think is what happened here. And so this is in a snapshot, the effect of COVID on HAI. Pretty dramatic increases for many things. Since that time, it's come down a little bit, I think, CLABSI and CAUTI, now that people have shifted back to their usual priorities. But for most things, it did not look good for a while. And it largely went underappreciated. Unless you're looking for HAIs, you won't necessarily find them. And so when the CDC then said, well, a part of the thing was many people stopped reporting during COVID. They didn't have the manpower to do that. So when reporting started again, and then people saw all of this that had happened, it was a big shock to all of us. So I will stop there Happy to entertain any questions and comments. Thank you to my collaborators here and students for helping with this very important work, and to our funding agencies for supporting this.
Alan had to leave, so I will do any questions.
Sure. Oh, is this a question?
Oh, there you are. I thought you said you had to leave.
I'm going to have to leave.
Okay. Okay.
I speak with lots.
Figure out, turn the other one
So
on.
Nasia, I'm mostly curious about MRSA and C. diff going in the opposite directions. I understand, I mean, if people, you don't test for C. diff and things like that, but then how come MRSA rates went up in COVID? And as 2020, is this post-2020, is this the same trend between MRSA and C. diff essentially?
Yeah, I think C. diff, there is a spectrum, and oftentimes you can have mild disease. And if you don't come in for that mild disease, you might find that your rates are lower because people aren't being tested. MRSA is not a subtle condition. If you have Staph aureus bacteremia, the mortality is very, very high. So those will come to attention, and I think part of that is that. I think the other thing is that we had a lot of attention paid to environmental cleaning in our COVID units. I mean, people were doing all kinds of things because it was felt that the virus would stay on surfaces for a long time before they found out that it didn't. And I think that probably inadvertently also helped C. diff. But the same attention was not being paid to other units necessarily. And so MRSA was pretty widespread.
Any other questions? I'll ask one. Vicki has one, but I'll ask one while I'm wandering over here. When we're talking about BPAs, and you mentioned that the fluoroquinolone usage has come down, so that BPA firing probably hasn't been as high. But so I'm just curious about, like, how do you continue to support that BPA in terms of making sure it's up to date, the alternatives it recommends are still there, and the resources the organization needs, and then when do you sunset these things or don't you, that kind of thing?
Yeah, that's a really good question. I think it's been very hard to determine what the right timing is, in part because most academic healthcare systems will have this big turnover. There's residents and fellows coming every year. So we feel that we still have to be pretty relentless. In case you're coming from an institution that used fluoroquinolones, you might feel that, you wouldn't know the culture here until you came here. But as to when there is a right time, there probably will be, I would think. I just don't know when that is. And we haven't looked at our BPA firing frequency lately, locally. I mean, I know our group has been looking at other sites that have been doing this, but I'll go back to them and find out what is the firing frequency. Yeah, it might be time.
Can you talk about the current status of infection prevention for hospital-acquired COVID?
So there's been a change, I would say, from the beginning to now. So in the beginning, when we didn't know as much about how COVID was transmitted, we had units within the facility dedicated solely to the care of COVID patients. And we tried to cohort not just the patients, but also the staff. So if you were, especially nursing staff, that you could be just dedicated to the care of COVID patients. And that, I think, helped to reduce transmission of COVID from one unit to the other. But it was not a very sustainable option because as our cases went up, there wasn't a way that you could just limit nursing or units. So now there's still some units that have more COVID patients than others, but it's pretty widespread throughout. When the public health emergency was lifted, before that, we were testing everybody coming in to see if they had COVID, because 50% of people did not have symptoms, so the only way to know is to test them. When the emergency was lifted and a couple years into the pandemic, again, it was one of those things that wasn't sustainable anymore. So now you could be coming in, unless you have symptoms, you wouldn't get tested for COVID. So we're treating it, that it's everywhere, which it is, and so we use what's called standard precautions. You assume everybody is potentially contagious unless proven otherwise. So staff will still wear masks, they'll still do hand hygiene, they'll still wear gloves for everybody, and then for the patients that are known to be COVID, you'd go beyond that by wearing an N95 mask when you go in, and a face shield and some extra precautions. But I would say that like anything else, in the beginning our focus was very relentless. We had people stand in the hallways to observe if we were all doing the right PPE and stuff, and that isn't really the case anymore. So I think just like anything else, there's a certain adherence rate to PPE, which is nowhere near the 100% that we would like it to be.
Yeah, for the prevention programs, so how easy to transfer those practice to another organization? So what are the key challenges in this duplicate those efforts?
Yeah, I think it largely depends upon the intervention, but I'll use the example of this antibiotic stewardship intervention. So there's, of course, a big spectrum of how facilities implement their interventions. And for anything that is EHR-based, which I don't think that I was very well versed in the beginning in this, there's a whole governance structure, and often these things are planned out, years in advance. And so you can't really go to the system and say, we're facing this problem, can you implement a BPA in the next 2 months? You can do that in the world of antibiotic stewardship if you can say that it's threatening patient safety, it's outside of the usual approval pathway. And so that's what we did for this. But when you go to another facility, they don't necessarily have those same rules, and they might say that our resources for IT are fully allocated and deployed, and we can't make the change. So then you have to work with them to do it in a different way. Maybe it's not in the EHR. Maybe it's a paper form that you use, or maybe it's the pharmacist that intervenes when somebody prescribes a fluoroquinolone. I would say many of our challenges have been IT and EHR based for that reason. And then staffing, I think, is very variable. In some smaller facilities, one person is doing stewardship, infection prevention, infectious diseases. They don't have the number of people that larger places do. And so how do you work with them to make the intervention work? For instance, very early on, when we had showed them our version of it, and we had said, if you have a physician who's unhappy about the fluoroquinolone, you could have them talk to an infectious diseases person that can reassure them if that's the case. Well, there are many places that don't have infectious diseases physicians on call. And so what do you do in that case? And so they relied on other people with expertise, like pharmacists or hospital medicine, both of whom were very capable. But we didn't know that until we went to them and talked about it. So those were some of the challenges we noticed.
So I have the statistic you shared about that if the patient before you had C. diff and then you go into their room that you're more likely to have, or is that still the case, or how do you, and as a future patient, how could I navigate that situation? Because it sounds like it's something to know about.
No, it is. And it's still recent data. It's not that old. There's now been quite a few studies that have all shown the same thing. And I think one question to ask is, how are the rooms cleaned for patients with C. diff? So for instance, we use these UV light robots that you seal up the room and then you send this machine in, and they'll take about 40 minutes to clean the room. And initially we had these very ambitious plans that every patient that was being discharged, their room would be subjected to the same cleaning. But it turns out that there's a lot of boarding going on in the ED. And in order to get the patients from the ED to their rooms, you can't have those 40 minutes to clean the room. It's that kind of time pressure that then people have to, prioritize. What am I going to do? And so we focused on, well, these protocols should be used for the rooms of patients with C. diff. Not everybody, but especially those that have C. diff. And that seems to have worked well because resources have now been focused on where they need to be. But that would be a question to ask, what are the cleaning protocols that are used in those rooms? And of course, the robots aside, most of this is all human behavior and human training.